unfortunately the graft failed and she had very poor visual recovery. The patient in 2010 developed acute eye drops in the right eye, but fortunately had a good visual recovery, and then started developing slow, painless diminution of vision in 2014 and presented to us in 2016. This was the clinical picture of her left eye. This was a clinical picture in the right eye, and as you can see very clearly, there was a scar of the resolved eye drops, an area of thinning which was off center, and cataract. The topography showed the size of the scar. At this point of time, there are multiple options. One of them is we do a combined procedure of keratoplasty, lens extraction, and intraocular lens implant, or we do keratoplasty followed by cataract surgery, or third is we simply do cataract surgery without keratoplasty. The patient had a bad experience with keratoplasty and was not very keen on undergoing keratoplasty. Therefore, we decided to go ahead with the cataract surgery alone. The question that came to our mind is, what type of intraocular lens are we going to use, and how presence of corneal scar and ectasia is going to modify our decision on the IOL selection. So the objective of my talk will be to discuss with you some of the anatomical facts of ectatic cornea and how these facts pose challenge as far as IOL selection is concerned, and the guidelines in the management of such eyes to get more predictive post-operative refractive outcome. Now you all are aware of that ectatic diseases of cornea are characterized by thinning as well as ectasia that results in irregular topography. There is increased corneal power, but unfortunately that increase is not uniformly distributed through cornea. The ectasia results in increased anterior chamber depth and there also the increased axial length. Now whenever you do keratometry in these eyes, you have to remember that the ratio between anterior and posterior corneal curvature is altered in these eyes with ectasia. The Placido's disc-based corneal topography systems are not very accurate because they scan the front surface of the eye, which does not give you accurate keratometry. And the third is that in the 3 millimeters zone, whatever corneal power you get may not be reflective of the total corneal power that this person has. At times, even the apex of the cone is not central, and this alteration in the location of the cone can affect the overall post-operative outcome. The increased axial length and anterior chamber depth in particular affect the effective lens position that may also alter the post-operative outcome. If you use the standard set of IOL formulae to calculate the intraocular lens power, they usually lead to hyperopic refraction, and therefore these patients have very unpredictable post-operative refractive outcome. So what are the solutions? What are the strategies that we can use for proper IOL selection? The first and foremost is that you have to ascertain the stability of ectasia. If keratoconus is still progressive, use collagen cross-linking or intrastromal rings to flatten cone. If the keratoconus is advanced, perform corneal procedure before you undertake corneal surgery. Ascertain the severity of ectasia. It is important because you can use measured K value for mild to moderate keratoconus, whereas you must use the standard K value for severe keratoconus. You should also make a note of location and centration of cone because that affect the spherical equivalent as well as cylindrical error that these eyes have. On the keratometry side, you should use Simflug-based imaging devices rather than Placido's-based topographers. And Pentacam usually give the best results on. You must also ensure that you take multiple readings and ensure that these readings are repeatable. As regards different IOL formulae, there are some modifications in the IOL power calculating formulae which are aimed for calculating IOL power for keratoconic eye. If we look at the performance of these IOL formulae, it has been found that the formulae which are modified for keratoconus are the best as far as the post-operative refractive outcomes are concerned. Other formulae, less number of the patients get refractive outcome within half diopter of astigmatism. Now the other thing that you have to keep in mind, while in stage 1 and stage 2 keratoconus, most of the formulae are very predictable. But when it comes to stage 3 keratoconus, the keratoconic formulae are best, or else you can use SRKT. All other formulae give very poor refractive outcome. You must have a target refraction based on the severity of disease. For stage 2, you should aim for more myopia, roughly about 1 diopter, and in stage 3, about 2 to 3 diopters of myopia. Avoid aspheric IOLs, because these IOLs are aimed at negating the positive spherical aberration. So if you put an aspheric IOL, you will have much higher degree of hyperopia post-operatively. What about toric intraocular lenses? For mild to moderate keratoconus, you get very good outcome from toric intraocular lenses. However, the toric intraocular lenses have to be avoided in progressive disease, where there is a very difficult refraction, and particularly in cases where there is a wide gap between visual acuity as measured with rigid gas permeable lenses and with the spectacles. So to summarize, the intraocular lens selection in ectatic corneal disorders is challenging. We need to be familiar with anatomical facts of such eyes and the guidelines that I just narrated to as far as IOL selection is concerned if you want to achieve the best outcome. The post-operative refractive surprises are common, and therefore it is important that we counsel these patients about the unpredictability that is associated when we operate cataract in these eyes. Thank you very much for your kind attention.
We have a microphone in the audience if anybody would like to come up and ask any questions. Judd?
Okay, Prashant, I just wanted to ask a question. One of the things that I think in some of the more severe cases is whether the patient's wearing contact lens. Because that will, of course, affect your IOL, basically, power as well. Because if you know that they're basically going to go back into a scleral lens or something like that as well, then, of course, that will then allow you to determine your variation, or it will give you a sort of a larger landing zone for the IOL. And I found that it's a lot easier, to be frank, if they're going to wear a lens afterwards, because then you can feel, okay, well, I can be a little bit more liberal with the lens choice that I'm basically going to put in. That's one thing I was going to say. And the other thing is that one of the things, especially in the higher levels, like grade 3 or 4 above, is that because your quality of vision is always impaired, because of course the coma level is still there from the keratoconus, which is not fixable by any basically procedure. On the lower grades, do you combine the treatment to try to treat the aberrations with any laser procedure after crossing? So what are your thoughts on that?
So what we can do is that you can either intraoperatively perform some of the procedures that are, or post-operatively you can do the refractive correction once you have the outcome of your cataract surgery. I think here I see definite role of light-adjusted intraocular lenses, and once these become commercially available, they are going to be of great help. Currently, one of the investigator in India is working on developing these lenses, and I'm sure that probably in 2025 we will have those lenses available.
Just to comment on the LALs, I would say that LALs, you can only correct up to 3 diopters of astigmatism there and 3 diopters of myopia or hyperopia. And for low levels of keratoconus, I have found you can get some good results. However, I just caution, the LALs are great. However, I just use caution even with keratoconus there. I think just like with the toric lens, there is some utility. However, it's not the panacea.
Yeah, I agree.
So I was just wondering, for this particular patient, this young woman, what did you choose?
Very good question. I removed those slides. I thought probably I'll be overshooting my time. But we left this girl a phakic. And then with contact lenses, she had 20/20 vision. And she was really happy that she had not to undergo corneal transplant.
Yeah, that was a good question, Audrey. That was one of my questions. So I have had such cases, and I can tell you, I ended up putting like 0 diopter lenses. Just didn't want to leave them aphakic because they're young patients. But in contact lenses, we got them to like close to 20/25. I've never had a patient except stage 1 keratoconus who did not need a contact lens after cataract surgery.
Ah,
They always need contact lenses for a couple of reasons. One, they're used to contact lenses, wearing those. Second, as Joe mentions, the quality of vision actually is better with a contact lens on, unless you're doing a transplant in future, which becomes difficult once you have somebody who's BCVA, kind of contact lens 20/25 or 20/26. I do use Pentacam, EKR values, they're useful. I think Naoyuki Maeda from Japan, he published a large series, and ages ago he basically asked me to use EKRs. I'm still using EKRs at about 4 millimeters. Pentacam gives out that reading, and I've been fortunate. They're usually within 3 diopters, which is good enough for these patients.
no, I had one patient where I did DSEC and post-RK cornea. That patient developed endophthalmitis, interface infection. And then I had to do the penetrating keratoplasty, and the patient ended up with -11 myopia. So another challenge that comes in ectatic disorder is if you have to do full thickness graft or other procedure, then you really get a refractive surprise of great magnitude.
Contact lens, yeah. Contact lens.